Welcome all to the very first TB Think Tank webinar session for the year 2026. And as a TB Think Tank Secretariat, we hope you all had a restful festive break. Today's session is titled Universal Screening for Asymptomatic TB Among Household Contacts and will be presented by Prof Simon Mendelsohn. So a brief introduction to today's speaker. Prof Simon Mendelsohn is a clinical investigator at the University of Cape Town, affiliated with the South Africa Tuberculosis Vaccine Initiative. He has contributed to over 30 TB vaccine and therapeutic trials and diagnostic observational studies, advancing our understanding of TB treatment and prevention strategies. His own research focuses on novel diagnostics to detect and manage early TB disease states and symptomatic screening for asymptomatic TB in high-burden communities. He is particularly interested in non-sputum-based approaches for diagnosing persistent tuberculosis infection and asymptomatic TB, integrating blood-based transcriptomic signatures and novel molecular techniques to guide targeted interventions. And with that said, over to you, Prof.
Great, thanks very much. And I'm going to try and share my screen. Okay, you should be able to see my screen now.
Yes, we can.
Right. All right. So thanks everyone for joining, and happy 2026. We're almost through January already, which is quite astounding. So maybe just to start off, I'll start with my acknowledgements. Just to say that the work I'll be presenting is from the larger Report South Africa Consortium, which is sponsored by, among others, this NIH and SAMRC, CDRF Global. And so the work I'm presenting is really from our collaborators, including collaborators at SATV, University of Stellenbosch, WITS, Pretoria, African Health Research Institute in KZN, as well as our US-based collaborators at Vanderbilt, UCSF, Colorado, and University of Washington. I thought I'd start with a case vignette, just to get us all in the same mindset when talking about subclinical or asymptomatic TB. And this is a participant who was enrolled in one of our community screening studies conducted in Worcester in the Western Cape. So this is a 26-year-old lady, HIV uninfected, and was asymptomatic, was not seeking care, was healthy, was in the community, regarded herself as asymptomatic as well. She didn't have any known TB contacts at the time of enrollment. She did have a history of prior TB. It's very common in our setting, but for the inclusion in the study, that TB episode was more than 2 years prior. In fact, it was closer to 5 years before enrollment. Again, very common in our community. She had a smoking history, but otherwise was very well, had a normal BMI, and on clinical examination, there were no abnormal findings, essentially healthy. To a either radiologist or to a clinician, her X-ray also looks pretty normal. There are 2 small lesions in the right upper zone, which look like small infiltrates or small nodules, which our radiologist and clinicians thought was either due to prior TB or was an artifact, wasn't significant. On further examination, might be a new node of TB, but not diagnostic of TB. In this case, her IGRA, her interferon gamma release assay, a quantiferon TB gold, was had a result of 10 international units per mil, which is high, sort of maxed out, but it's again not abnormal in our setting. In our setting, 75 to 80% of adults are IGRA positive, so we don't really use this as a marker of disease, and it doesn't really tell us if there's current or previous infection. So to her CRP level, C-reactive protein level, was 1.8, which again is low, not particularly alarming. So to a clinician, this would not be particularly suggestive of TB, and in fact, this participant was not followed up we didn't think this participant was at risk of TB in our setting. However, 18 days later, her sputum culture result came back positive. Expert result was also traced positive, and her sibling was also enrolled in the study, also had pulmonary TB and started on treatment. In the case of this participant, she was referred to the clinic for treatment. They repeated her sputum sample collection. Her repeat expert test done at the clinic was negative. And so she was not followed up at the clinic. But a year later, we followed up with this participant ourselves. A year later, her TB did return, and she was started on treatment roughly a year after this event. So we define asymptomatic TB as individuals without, not aware of, or not reporting the signs or symptoms of TB. And in the figure I'm showing you on screen at the moment, this is from a systematic review and meta-analysis of prevalence surveys conducted in Africa and Asia. What's quite astounding is that roughly 50% of individuals who were diagnosed with TB in these prevalence surveys were asymptomatic, did not report symptoms. Now, one thing that needs to be bear in mind when you look at the methodology for these prevalence surveys, many of them pre-screen individuals with either chest X-ray and or symptom screening. So all individuals who were diagnosed with TB in these prevalence surveys, before they provided a sputum sample, would have had either a positive X-ray or a positive symptom screen. And among those, 50% were asymptomatic. So what this sort of alludes to is that there may be another group, an extra group of individuals who do not have symptoms, have a normal X-ray, which is the vast majority of individuals who are screened on a prevalence survey, and a small fraction of those individuals we believe will probably have TB, and those are the individuals who are missed from these surveys. And that's, in terms of proportion, it's a small proportion, but in terms of actual numbers, it's probably quite a large number of individuals. What are the implications of this for community-based screening or screening of high-risk groups? So this is a figure from both from the WHO consolidated guidelines on screening, which is adapted from a Cochrane meta-analysis, looking at the sensitivity and specificity of different screening tools. And the sensitivity here given for the symptom screening is 71%, chest radiography 94%, or for just suggestive abnormalities 85%. But to bear in mind here as well, most of this data, the sensitivity and specificity data, is based on the prevalence surveys, which exclude the group who are asymptomatic and without chest X-ray abnormalities. So we're concerned that perhaps these estimates are overestimating the true sensitivity of symptom screening and X-ray screening, because they may be missing this group that's highlighted in green over here, those who are X-ray and symptom negative. So the key questions we wanted to answer was, what is the true proportion of TB missed by symptom screening and chest radiographic active case finding approaches? What is the clinical phenotype of this asymptomatic TB group? And could we use alternative blood-based biomarkers or other tools to detect this group if chest X-ray and symptoms could not detect this group? So starting with the first two questions, we first reviewed the literature. So we went back to that Cochrane meta-analysis, and we reviewed all the studies included and went through their reference lists, did forward citation tracking, and looked for studies which included this group in green, included individuals who were chest X-ray negative and symptom negative. What that basically meant for the methodology of the studies we included is that they had to perform universal sputum testing. So they collect sputum samples from all comers, irrespective of symptoms, irrespective of chest X-ray findings. And we found very few studies which actually did this, most of them quite small, many of them in high-risk groups. So just to give you an example, we excluded individuals with HIV. There were a number of studies among HIV-positive individuals, but these were studies among minors, household contacts, people deprived of liberty, again, close contacts. Those were the majority of studies that did universal screening. So roughly 20 to 25 studies which did universal sputum testing and asked whether people had symptoms. And in these studies, consistent with the Cochrane review, we also found a sensitivity of about 50%, just to point out the high heterogeneity between these small studies, but about 50% sensitivity for sputum for symptom screening in this population. Even fewer studies collected universal sputum and did a chest X-ray screening exercise. So we limited it to studies published after 1980, but still found a few published in that decade. Again, very few, roughly 10 studies performed universal sputum testing and performed X-ray, and sensitivity in that setting for X-rays was 62%. Again, high heterogeneity between these studies. And even fewer studies collected data and had that published online for both symptom and chest X-ray screening with universal sputum testing. And there we have a combined sensitivity of about 67%. So indicating that even with X-ray screening, we're missing about a third of individuals by doing pre-screening with X-rays or symptoms. Sorry, I see a hand raised. Is that about the sound or the video?
Audio and visual is okay from my side. You may go on. Questions will be addressed at the end of the session, colleagues. Apologies, Simon.
Okay, sure, no worries at all. Okay, so that's what we found in our meta-analysis. We also then proceeded to do a prospective study looking at household contacts of indexed TB patients, adult household contacts over 18 years of age, enrolled participants at 3 sites in South Africa, 1 in the Northwest province and 2 in the Western Cape region. We performed a universal symptom screening for cough, fever, the usual sort of TB symptoms of any duration, as well as performed a chest X-ray on all individuals for any abnormality suggestive of TB. We collected serum samples for C-reactive protein testing. This we tested with a multiplex bead array rather than a lab certified diagnostic test. And we also collected universal sputum samples from all individuals who were able to produce a sample. And we tested that with expert ultra, midget culture, and smear microscopy with a microbiological reference standard, which included either positivity with midget culture and or expert ultra, but excluded the trace results from the reference standard. So just some of the headline findings. We enrolled 979 household contacts. Among those 979, 51 or 5.2% were found to be to have microbiologically confirmed pulmonary TB. The remainder did not have TB at baseline. A few of them did progress over 12 months of follow-up to TB. I'm not going to discuss those individuals now. Among those 51 cases, 30 of them, so more than half, were positive by both expert ultra and midget culture. About a quarter were positive by midget culture only, but confirmed by sensitivity testing. And then we had 8 who were ultra positive only, so that's about 15%. And most of those, some of those had a previous TB episode, but the enrollment criteria was that they couldn't have had previous TB within the previous 1 year. So 2 of them had previous TB between 1 to 2 years previously. And we excluded the trace positive results from this endpoint. Of those 51 TB cases, the vast majority, 80%, were asymptomatic, and only 9 were symptomatic, roughly 20% and 80%. So if you look at the control group, we find sort of similar proportions. And then looking at the features on chest X-ray, of the 51 TB cases, 31, so 60%, had an abnormal chest X-ray. If we look by symptom status, so again, we had 9 symptomatic TB cases and 42 asymptomatic TB cases. Among the symptomatic TB cases, these are people who had symptoms of TB, but thought these were normal symptoms or hadn't sought care for the symptom, hadn't gone to clinic yet. Among these individuals, 8 out of 9 symptomatic cases had an abnormal X-ray. And among the asymptomatic TB cases, roughly half, just over half, had an abnormal X-ray. So many of them were asymptomatic, were not seeking care at the clinic, but only half of them had an abnormal X-ray and would have been picked up through screening. Looking at the smear microscopy results, of the individuals who were asymptomatic, of the roughly 42 asymptomatic individuals, the majority, 69%, were smear negative. Roughly a third, 13 out of the 42, were smear positive. And then if we look a bit closer at those individuals who were smear positive, of those 13, almost 2/3 of them were scanty or 1+, and the remainder had more bacilli on their AFB positive bacilli on their smear. So the majority were porcine bacillary on their smear. If you weigh these all together, how does symptom screening and chest X-ray perform as a screening tool in household contacts? So if we don't do any pre-screening, we just do a midget culture and an expert test on everyone. That'll be 51 cases we would be detecting. If we had an endpoint which included either positivity by expert ultra or midget culture, it would detect 51 cases. If we only did expert ultra on all individuals and used our culture as our endpoint, as our reference standard, we would detect roughly 84%. So this is sort of the current state in South Africa. We're using sputum expert ultra. And if we were to do a symptoms pre-screen of individuals, so before collecting a sputum sample, we would, as mentioned earlier, would miss about 80%. Would detect roughly 20% of cases through symptoms. Through chest X-ray, we would detect roughly 62%, which is in keeping with our meta-analysis that we performed. And if we did parallel symptom and chest X-ray screening before collecting sputum samples, we would detect about 64%. This is, of course, using a reference standard which includes both expert ultra and midget culture. If you were to just perform expert ultra, we would miss many of the cases as well. So the take home from this first section, what proportion of TB cases would be missed through a symptom screening and chest X-ray active case finding approach. So symptom screening alone would miss about 8 in 10 cases. Chest X-ray screening alone would miss about 3 in 10. A combined approach would miss roughly 2 in 10 TB cases. What is the clinical phenotype of asymptomatic TB? Asymptomatic TB was often paucibacillary and without typical features of active TB on chest X-ray. The third question we wanted to answer was, could we detect asymptomatic TB using blood-based biomarkers? And the most commonly used blood-based biomarker in this sort of setting, other than IGRA or quantiferon or a T-spot, LE-spot test, would be a non-specific host-based signature, so something like or biomarker such as CRP, C-reactive protein. And this is something that's been advocated by the WHO for screening, particularly of people living with HIV. But most of that data comes from individuals who are presenting to care or hospitalized, not in community or active case finding approaches. So we want to look at how well does CRP perform to distinguish healthy household contacts from those with TB. This work was done by a student in our lab, Dominic Arefdin, together with collaborators and Novel Trigui and others at the Stellenbosch University. I'm just going to orientate you to this figure. So on the y-axis, we have CRP, C-reactive protein concentration. This is again measured using a multiplex bead array, not using a standardized laboratory diagnostic test. So the values might not be aligned perfectly with what one expects for a standard diagnostic test, but they are illustrative of how well a CRP performs as a diagnostic biomarker in this setting. To orientate you to the x-axis, I've got two populations. Firstly, the household contact of index TB cases. So these are the individuals I've been talking about to this point. For this sub-study, we had only a subset of the participants included in the previous data I've shown you. So including about 126 who didn't have TB, roughly 25 individuals with asymptomatic TB, and 7 in the households with symptomatic TB. On the right of this figure, I've got another cohort I haven't described yet. This is also from the Report Consortium, also from South Africa. These are individuals who are seeking care at clinics with symptoms of TB. One of the inclusion criteria was a cough for 2 weeks or more. So these are sicker individuals. In the green, I've got people who did not have TB but were symptomatic. And in red, I have the symptomatic TB cases diagnosed at clinic. So just the first observation that you'll probably be able to see is that the median CRP concentrations in those who were diagnosed with TB at the clinics were significantly higher than those without TB at the clinics, as would be expected, and the range is much broader in the clinic than in the household population. We see a pretty similar median and interquartile range between those with no TB in the households and those with no TB in the clinic. However, you can see a much wider range of results among those attending clinic, because these are individuals who have other respiratory conditions. So that's the first major finding. The second major finding you'll note is that although quite a small group, only 7 symptomatic TB cases in the households, those in the clinic have much higher median CRP levels than those in the household. These are probably sicker individuals who are seeking care. And then the other most significant finding is that we cannot accurately differentiate those who have asymptomatic TB from other household contacts. So the CRP levels, median CRP levels in asymptomatic TB cases are very low. We can differentiate symptomatic TB cases in the household. Again, this is a weaker phenotype, but we're able to differentiate symptomatic TB cases in this small group, but not in the asymptomatic TB cases in the households. What does that mean for actual sensitivity and specificity? So CRP performs pretty well as a triage test in the clinic setting, as we expect. It has a sensitivity of about 86% at a 70% specificity, which approaches the WHO pre-specifications, their target product profile for a triage test. If we move to the household contact setting, though, among the symptomatic cases, the sensitivity is only 70% at a 70% specificity, indicating it doesn't really work very well as a screening test in the household contacts or community setting. In fact, we'd expect it to perform even poorer in a community-based setting. And then finally, how well does it work to differentiate asymptomatic TB cases versus those with no TB in the households? Here it has a sensitivity below 50%, 48% sensitivity at 70% specificity. So it doesn't really work well at all to find asymptomatic TB cases. In fact, you do better by using, or as well, just use chance, flip a coin. So the take home from this, can asymptomatic TB be detected using blood biomarkers? Yes, we can use tests like CRP, but there's much less inflammatory signal among household contacts, among people with asymptomatic TB or mildly symptomatic TB detected in households and community settings. And in this sort of setting for active case finding, biomarker performance is poor. So just to summarize the main findings that are presented today, first off, the majority of prevalent TB cases we found among household contacts were asymptomatic, more than 80%, which is higher than was found in the meta-analysis I presented at the start of the presentation, and also higher than was found in our own meta-analysis, where we looked at only those studies which performed universal sputum collection and testing. Asymptomatic TB was characterized by low bacillary load, so it was paucibacillary, low CRP, low inflammatory biomarkers, so not much of a host response, so indicating sort of early or minimal disease. Most of the individuals, more than 40%, did not have a chest X-ray suggestive of active TB, had a normal chest X-ray, and those results were in keeping with what we found in our own meta-analysis. So symptom screening would miss about 80% of cases. Chest X-ray screening would miss about a third of cases, and if you combined chest X-ray and symptom screening, you'd miss roughly 2 in 10 cases, roughly 1/5 of cases. And serum CRP screening would miss more than 50% of cases, so it's not much better than coin toss. What are the implications of these results? Of course, this is a small household contact study. The data is supported by the results of our meta-analysis as well from other studies which have conducted universal sputum collection in diverse high-risk groups and other community-based settings. They find similar results. So looking at the positive, using symptom-based and chest X-ray pre-screening approaches for prevalence surveys or for active case finding approaches in the community and high-risk groups, such as household contacts or people who use drugs or people deprived of liberty, you would still detect about 60% of cases which would not otherwise be diagnosed. So that's a still very, very positive finding, that our current approaches are better than nothing, better than not doing screening. So we are finding significant number of cases. The alarming implication of our findings is that we are leaving behind about 40% of cases, and from our data, among those asymptomatic individuals, roughly a third were a sputum smear positive. They probably are infectious, and many of the others who weren't infectious may progress to infectious TB and are a risk for ongoing transmission to other household contacts, to other members of the community. So we are potentially leaving behind 40% of cases following this approach rather than using a universal sputum screening approach. And of course, there are many cost implications of performing universal sputum testing versus using pre-screening approaches of symptoms or chest X-ray. So the question really is, from this presentation, is there a role for universal sputum screening instead of doing pre-screening in prevalence surveys and high-risk populations? Are we missing a substantial proportion of TB? And what are the implications of missing these cases? Is there a risk of ongoing transmission of these individuals? How many of these individuals self-cure, don't actually need treatment, maybe just need nutritional support, for example? How many actually need full TB treatment? What is the treatment for these individuals with minimal or asymptomatic TB? We don't know. Those are the sort of unanswered questions. Regarding CRP and other biomarker testing, what's evident here is that triage tests like CRP, which were developed and have been validated for symptomatic TB, for passive case finding among clinic attendees, do not perform well for finding this asymptomatic TB in community settings, such as among household contacts, because we feel that this is sort of a weaker phenotype. This is an earlier stage of disease, a more minimal stage of disease, and there is much less of a host response. So host response biomarkers particularly do not seem to perform well in this population, unfortunately. There is hope for more specific biomarkers. Unfortunately, in our setting again, an IGRA test or TST is unreliable because certainly in our setting, most of the population by early adulthood is IGRA positive, and so would not be very useful for stratifying whether people have TB or not. But markers such as T-cell specific MTB activation assays, which take IGRA a step further and say whether individuals have had recent exposure, recent infection, whether the MTB T-cell phenotype is an activated phenotype using an activation marker. There are potentials for applying a more specific marker, something that tells you there's an active or persistent infection, someone who may be at risk of progression to disease or may have current disease. So that's an alternative to current host-based biomarkers, so the CRPs or transcriptomic signatures that have been studied extensively in recent literature. And that's where I would put my money at the moment. And with that, I'm going to end on the half hour. I'd like to thank our broader collaborators again within the Report South Africa and Report International Consortia. And thank you all for listening. And with that, open to questions and discussion.
Thank you so much, Prof. Simon Mendelsohn. We will now go over to our Q&A or comment section. Our first question is Dr. Carl Leroux. You may go ahead and ask a question.
Thank you very much. Yes. Can you hear me?
Yes, we can.
Thank you very much for the presentation. I just had a question in terms of the studies that you looked at. So I did put it in the chat, but when you said there was universal sputum testing, I assume, I mean, some of those studies are quite old. That was primarily AFB testing, or was that also culture testing that was used in those studies? So I just want to get clarity because the one is so much more sensitive than the other. So I just want to get the understanding of those studies that you looked at before. My second question was just around the midget culture. I haven't been in clinical medicine for the last year or two, and so I haven't heard about midget culture. If you could just go into a little bit more detail about that, and then in terms of it seems that you had real success with with your sputum testing in the study that you pretty much diagnosed everybody that you diagnosed using sputum, but were you able? How easy was it to get sputum from everyone? I think that's always been my experience with the work that I've done in the rural Eastern Cape, that we often struggle to get sputum from household contacts. And is that kind of considered in your outcomes? And then the last one was just around, you looked at the different modalities of culture. I mean, sorry, asymptomatic versus or symptoms versus symptoms and chest X-ray versus symptoms and testing. But do you ever just look at the? I mean, in our context, it's unlikely that we're going to have universal. I don't really know the cost of midget culture, but that's going to be available to the country widely. What is available in rural is X-ray, symptoms, and gene expert, and so it'd be nice to see, kind of get a sense of what the sensitivities are of those, but not with culture. So those are my three main questions. Thank you.
Sure. Let me start with your first question. So one of the inclusions in our meta-analysis was only studies which use culture or molecular techniques. So, and those studies in the 1980s, if I'm not mistaken, used LJ slants, so solid culture medium. So that was our inclusion. So we didn't include those studies which only used AFB for diagnosis, of which there were a number. The difference between midget culture, so midget culture is a form of liquid culture, a liquid culture medium, mycobacterial growth inhibition tubes, versus the traditional older solid culture, LJ, Lowenstein-Jensen medium. The advantages of a liquid culture is a contamination, but also so less contamination as far as I understand. Also high sensitivity as far as I know. The others on the call who are microbiologists will correct me in that regard and any other benefits. In terms of sputum collection on the study, we always, at our particular site, for a variety of reasons, we were really successful in collecting sputum samples. So we collected samples from 97% of participants. We didn't verify the quality of the specimen. So we tested sputum irrespective of whether it was high quality or not, whether it appeared as viscous or liquid, whether it looked like spit or whether it looked like sputum. And we do find some samples which have got inadequate quality. We test some of those positive as well. So we test irrespective of the quality. We didn't perform sputum induction. These are all spontaneously collected samples. And we, as I said, we managed to collect from most individuals. Just to bear in mind, our population has a very high rate of smoking as well, and over 50% of participants smoke. So that might make it easier to collect sputum samples in the population as well. But that's a very valid point that is often a concern, especially among household contacts or healthy community members, whether it's possible to collect a sputum sample at all. And then the final question, what happens, can we use Expert Ultra as our reference standard or using it as our confirmatory test? So when we look at using an approach where we perform universal sputum testing, but only with Expert Ultra and use culture as our reference standard, then Expert Ultra has a sensitivity of about 84%. I don't have the figures offhand, or on hand rather, how an approach with symptoms and or X-ray plus expert performance versus using culture as a reference standard. I've got those data somewhere, but I don't have those on hand. But it would be less than 84% sensitivity because your expert alone had 84% sensitivity. So there we go. So I hope that answers your questions.
Thank you.
Thank you, Dr. Leroux. So we have Susan here who asks, what are the implications for preventative therapy? Many individuals with TB will be treated with a single drug. What are the risks for drug resistance?
Yeah, again, I'm not an expert in drug resistance, but that's a very good point. So many of these individuals with asymptomatic TB, some of them had features on X-ray, had cultural TB, and we were treating them essentially. The study was conducted before 3HP. We were treating them with isoniazid preventative therapy. The few that did actually get preventative therapy. So I suppose there is a risk of monotherapy for people with with drug-sensitive TB and the risk of drug resistance developing. Absolutely, I can't give you the proportion risk, but certainly that is a consideration. And as I stated as well, we also don't know yet. It's probably unlikely that these individuals need a full 6 months of therapy. It might also be the case that some of them will be fine with 3-HP or 6 months of isoniazid, but we don't know what the happy medium is, or whether we need to stratify risk of drug resistance or of treatment failure, and whether they need different regimens or what the applicable regimens are. And I'm sure a lot of people are currently designing studies on how to treat these individuals, on what the appropriate regimen is. But probably it isn't 6 months of isoniazid. It's probably somewhere between 6 months of traditional TB treatment and what we currently use for parental therapy.
Thank you so much. We have a question here from Riwan that says, how was your experience obtaining sufficient quality sputum samples from the asymptomatic household contacts? Did you perform induction?
Yeah, so I think I answered that a bit briefly earlier. We didn't perform induction. In our setting, we were able to collect 90% samples from 97% of individuals. Some of them would have been inadequate quality, but we tested them anyway. I can't give you the exact numbers of how many of the inadequate ones were positive, but many of them were positive from spit samples.
Thank you so much. I'd like to give an opportunity to Tom Boyles, if you're able to unmute yourself and speak to your comments, Tom.
Oh, I didn't ask to speak.
I just thought it would be great.
I mean, I can comment on the CRP. I mean, just to say, having a different median in the patients in the clinics, having a different median CRP tells you nothing. CRP has been tested in symptomatic patients many times, and it's hopeless. These patients can produce sputum, and they need sputum tests. And we should abandon CRP in these clinic attendees. It tells us nothing. That was all I was saying. It's really the world's worst test in symptomatic people with cough. If you'd like me to comment on anything else, I'm very happy to.
Are you all right with that, Prof Simon?
I totally agree. If someone is attending clinic and they can produce a sputum, why do a CRP or why do a host response test if you can just collect the confirmatory test, which costs the same as doing the CRP?
Okay, thank you. We also have a question that asks, what are the risks of transmission for asymptomatic TB? Based on your studies you have looked at, is there any data suggesting progression to active TB disease? Would you advise treatment of asymptomatic TB, and if yes, for how long?
So absolutely would recommend treatment for asymptomatic TB. I think it would be, for a treating physician, very difficult not to treat, with the potential risks of not treating. The question of what to treat with, that speaks to my answer. But earlier, we don't know yet, and I know there are studies that people are starting to look at different regimens. It's somewhere, as I said, somewhere between 6 months RHZE and 6 months of isoniazid. It's somewhere in the middle. It might be differentiated treatment depending on extent of disease or mycological findings, but we don't know yet what the optimal treatment is. And transmission risk, our study didn't look at transmission risk. Unfortunately, we weren't able to connect. We didn't enroll the index cases, so we aren't able to look at the risk of transmission to the household contacts, nor did we follow the other household contacts of these asymptomatic cases. So we're not able to look at or to quantify transmission from asymptomatic to other individuals. I know there are a number of other studies which have been doing this. So, for example, enrolling household contacts, looking at symptom status, and doing IGRA testing, particularly of children, for example, and quantifying transmission risk to children in those households. But in our study, we unfortunately didn't look at transmission, and it's a tricky thing to do in this sort of setting.
Okay, thank you. We have a question that asks, would pooled expert ultra be the optimal screening for household contacts then? How about plus life on sputum and tongue for sputum scars? Will sensitivity be sufficient?
Yeah, potentially. So we like plus life. We're starting to try it out in our setting as well. You get a result very quickly within half an hour. So potentially you could take a device into the household and do testing there and then get a result and start treatment straight away. Pooled sputum, it has logistical challenges. It's certainly a possibility for mass community, mass household screening. I think that if someone is a household contact, it puts them at significantly raised risk. In our study, 5% had microbiology confirmed TB. So in my opinion, I think it's a low-hanging fruit, this population. There's a high yield of TB cases. So I think that every household contact should be getting a sputum test irrespective of symptoms. In the general community and general population screening where there's less risk, there perhaps pooling sputum samples or using something like the Plus Life device would be really beneficial to reduce the number of tests done, but it has logistical challenges. So yeah, I'd say definitely individuals in the households need testing, sputum testing.
Okay, thank you. And colleagues, just a reminder, if you would like to pose a question, you can raise your hand and then you could unmute. We have a question from Dr. Calderu again. Does anyone on the session know the cost of midget culture versus Gene Expert Ultra? Perhaps that was not supposed to be read out loud. If anyone does know, perhaps you could respond in the chat. Or do you know, Prof?
Offhand, I can't. For Gene Expert Ultra, you're looking at roughly, it depends on the subsidized or not, but it'll be under $10 a test. I think we pay close to 150 Rand for Expert Ultra. But that's from a private diagnostic laboratory, and I think they can be bought at a lower price. And culture alone, just to do the midget culture, is actually not much more than that. Again, in a private diagnostic laboratory, but then you probably want confirmatory testing on your isolate as well, which might add to the cost. I'm not an expert to speak on that.
Okay, thanks, though.
The downside, though, of the culture, of course, is that you're going to wait up to 6 weeks to get a result for the culture, whereas with the expert or the Plus Life that someone mentioned earlier, you're going to get a result within a day or two.
Okay. Okay, thank you so much. Any other comments or questions that people would like to ask our presenter today? Whilst we wait for a question or comment, this is just a reminder that if you would like to be on this platform in the upcoming months, please do email myself at ngosi@tbthinktank.org so that you could be on this platform as well. I'd just like to ask, does anyone, whether it's Pali or Pauline or Graham or even Neil, if you'd like to add a question or comment and unmute yourself? Or Grant? Graham, you may go ahead.
Thanks, Nolwazi. I typed one question in the chat.
Okay.
And thanks, Simon, for a great presentation, really interesting and provocative findings. Just regarding the people with, confirmed TB and a normal chest X-ray asymptomatic, how stable do you think that clinical phenotype is? And could it, at least in some people, just represent kind of mucosal colonization that's transient? Is there any data that could speak to an answer to that?
Yeah, so thanks, Graham. That's a very interesting question. So we definitely think that there's variability, and in this case, we collected a single sputum sample at a single time point. We don't think this is the optimum sample collection. Probably if you want more definitive sample collection, you want to collect probably 3 sputum samples. Probably want to space it out, maybe not even in the same day, over days or weeks. And ideally, you want to test all those samples by culture, by your reference standard as well. So it's not the optimum sample collection methodology. We also think that there's transient. People have transient colds or flus, or these are smokers. They get aggravations of their chronic lung diseases, and they at some points become more sputum productive, and perhaps that's what we're seeing as well. In this particular population, with the high rate of smoking, for example, people are more able to produce sputum samples, and that's why we're finding more TBs, that are just people able to make better sputum. So certainly we need to collect, I think, more sputum samples to have a better understanding of that transient nature of this of TB. If we are finding, we found a lot of these individuals had porcibacillary disease. They had they were either smear negative or had 1+ or scarce AFBs on their smear. Majority were expert ultra trace positive. They had high times to culture positivity. And so we were picking up people right on the cusp, of negativity. There probably were plenty of people who, if we collected a second sample from, may have been positive as well. So we might have been picking up sort of people with porcibacillary. There plenty more probably who were not detected because the tests just weren't sensitive enough, and we only collected one sample. So probably for better design, you'd want to collect multiple samples, multiple time points, test them all by culture. The question to whether this is colonization or true disease, that's a more controversial one. I think there you need to follow these individuals up to see what happens to them. And we know that plenty of them will self-cure or self-clear. And many of them, most of them probably won't progress to disease. But it's very difficult to do those studies in an era of TB micrological therapy where we can't not treat them. So I know Bianca's work has looked quite a bit at that, and there I know she's shown that about 10% with X-ray findings do progress to disease over the next few years. But yeah, very difficult to know whether this is just a transient state, whether they self-clear, or whether they need treatment.
Yeah, I mean, Simon, just to sort of carry on from that, the challenge is that finding this extra 36% of people, if we had to kind of, as a health system, decide that was a priority, to find them and get them onto treatment, would have huge health service and resource implications. And to my mind, there are a number of questions about, what the significance of this population is on a public health level. How much transmission are they responsible for? What is their risk of progressing to disease if they're not treated? And simply, saying that we found them and therefore we, in a study, and therefore we need to, as a health system, find more of them. I think there are a few more questions that have to be answered before that significant resource dedication of resources is made, and but clearly very provocative findings that need to be pursued.
Absolutely, yeah. So the implications of this is still unclear. Yeah, do we need to treat them? For how long? What happens if we don't treat them? Are they responsible for the transmission question someone asked earlier? Are these individuals actually transmitting? If they're not, then and they're not, most of them don't progress to disease, do you need to treat them at all? Can't we just wait till they develop symptoms? That's all unanswered questions. Yeah.
And then if you triangulate it with Robin Wood's findings about 3/4 of people have it in their exhaled breath, in a community with high transmission, it suggests that that there are people that do have transient mucosal TB, and it's not reflecting in parenchymal disease. It's not causing host inflammation, as your CRP data showed, and perhaps in a significant proportion it does self-clear.
Yeah, absolutely. Yeah. I'm more skeptical of the idea that I can't remember the figures of it's 2/3 are colonized. But certainly a lot of those individuals, in our study, 5% are actually aerosolizing the TB, or at least it's in their sputum. Yeah. But yeah, more skeptical of the fact that 2/3 are carriers.
Thanks.
Sure.
Thank you, Graham. Angelique, I see you've dropped your hand now. Would you still like to speak to your question or pose a comment? You may unmute yourself. Okay.
Thank you, Simon. Thank you, Nolwazi. Very interesting presentation. It was just a follow-up from the question from Graham, and especially your comment regarding the methodology to confirm if it was a transitional state. When you say that it needed to have a different sputum collection at different time of point to confirm if this state was permanent or just transition, I think it will be difficult because when you detect the first sputum and it's positive, you'll treat. I think the question is also around, shall we treat or not? And will you let this type of patient untreated with that type of result of positive sputum result? So when you start treating, the likelihood for you to find positive sputum diagnostic at different time point will decrease because you will treat in a way or another. So it might not be easy to confirm if this status will transition or will progress to disease because you have treated. And from that point of view, I'm not sure that subsequent sample collection will answer the question. I think it was just a comment and to see what you think.